Today, we'll be looking at Liaison Psychiatry. My name is Dr. Boakye-Boama. I'm a medical doctor and a resident in the Psychiatry Department, Kumasi, Ghana. My email is peterboakye27@gmail.com. Have you ever been sick such that a lot of investigations have been done but no conclusive diagnosis has been given to you? Then possibly this lecture is for you. Liaison Psychiatry. Definition is concerned with the assessment and management of psychiatric and psychological illness in the general medical population. This means that especially on other wards, excluding the psychiatry ward. Acute confusional state, that's delirium, is characterized by acute onset of fluctuating cognitive impairment, associated behavioral abnormalities, and is more common in people who have chronic impairment already, such as dementia. Clinical features of delirium include attention deficits, disorientation, sleep problems, agitation, hallucinations, thought disorder, paranoid delusions, and is rapid with fluctuations over several minutes and hours. There are three clinical presentations of delirium, which are hyperactive delirium, where there is psychomotor agitation, hyperactive delirium, where there is psychomotor retardation, and mixed delirium, which is a combination of both. Etiology of delirium. The etiology is frequently multifactorial, such as infective causes, that's UTI, chest infection, wound abscesses, cellulitis, etc. Metabolic causes such as anemia, electrolyte imbalance, hepatic encephalopathy, uremia. Intracranial causes such as CVA, head injury, encephalitis. Endocrine causes such as pituitary, thyroid, diabetes mellitus. Substance intoxication such as alcohol, benzodiazepines, among others. And hypoxia, secondary to any cause. Cause and prognosis of delirium. It usually has a sudden onset with a fluctuating clinical course. There is gradual resolution of symptoms with effective treatment of the underlying cause. Thus, to manage delirium, we mostly treat the underlying cause. Symptom resolution may be much slower in the elderly population. There is often patchy amnesia for the period of delirium following recovery. Assessment of delirium. You attempt promptly, you review the past notes, you examine the patient record for any drugs that may be associated with confusion, and you establish the pre-morbid function from the relatives or general practitioner. Management of delirium. The general measures are written here. Delirium, which is caused by alcohol, is mostly treated with oral lorazepam or benzodiazepines. But if it's not caused by alcohol, it's mostly treated with antipsychotics such as oral haloperidol 0.5 to 1 mg or oral risperidone 1 to 4 mg. Now, medically unexplained symptoms. This addresses where you go to the hospital and a lot of investigations have been done, but no diagnosis has been given to you. Medically unexplained symptoms definition. This is where patients have symptoms for which, after adequate investigations, no cause can be found. Clinical presentations are four. That's 1. Somatization, 2. Conversion or dissociation, 3. Hypochondriasis, and 4. Factitious symptoms. Details of the clinical presentation. 1. Somatization disorder. Here there is repeated presentation of medically unexplained symptoms, MUS, affecting multiple organ systems, first presenting before the age of 40 years. Chronic cases will have large number of diagnostic procedures or surgical treatments. The differential diagnosis of somatization disorder include undiagnosed physical disorders such as HIV/AIDS, TB, multiple sclerosis, other somatoform disorders that may occur such as somatoform pain disorder, hypochondriasis, conversion disorder, factitious disorder, and malingering are all possible differential diagnoses. Management of somatization disorder. It's important that there is review by a single name doctor. Reviews should be planned and agreed at a good frequency to avoid emergency consultations. Symptoms should be examined and explored to view their emotional meaning. All secondary referrals should be made through one individual, and it should be noted that the patient can exhaust the doctor's resources, so you plan to share the burden over time. Prognosis is poor in the full disorder, thus it tends to be chronic, but children and adolescents, rehabilitation and engaging in other activities usually help with recovery. Under somatization disorder, we have somatoform pain disorder. Here there is persistent and distressing pain not explained by organic pathology. It's important that you recognize and treat comorbid depression as part of its management, and psychological treatments such as CBT are done. Bodily distress disorder, also under somatization disorder. Here there's a presence of bodily symptoms that are distressing to the individual, usually multiple body systems varying over time. The distress is usually pain or fatigue. Mild, moderate, and severe forms are differentiated in ICD-11. 2. Dissociative or conversion disorders. Dissociative disorders involve disruptions in awareness, memory, identity, or perception, often triggered by trauma, causing feelings of detachment from reality or self. Conversion disorders, also called functional neurological symptom disorder (FND). They manifest as neurological or physical symptoms such as paralysis or blindness with no underlying medical cause, but are linked to psychological distress. The clinical features of dissociative or conversion disorders are 1. Paralysis, 2. Loss of speech, that's aphonia, 3. Sensory loss, 4. Seizures, 5. Amnesia and fugue. In fugue, there is a history of travel outside the patient's normal environs. Thus, the patient travels away from home. They have no memory of how they got to where they presently are because there is amnesia for the period for which they traveled, but they supposedly behave normally during the period of time they traveled. Treatment of dissociative or conversion disorders. Physiotherapy for physical problems. Then you treat comorbid psychiatric problems. Then cognitive behavioral therapy. 3. Hypochondriasis. Hypochondriasis is preoccupation with the fear of having a serious disease, which persists despite negative medical investigations and appropriate reassurance, with subsequent distress and impaired function. Clinical features of hypochondriasis is such that they are preoccupied with the idea of having a serious medical condition, and they are unable to be reassured in a sustained fashion by negative investigation. You must know that the form of belief is kind of an overvalued idea, but when it becomes of delusional intensity, the patient should be treated as for delusional disorder. The cause of hypochondriasis can be related to childhood illness, parental illness, excess medical attention seeking in parents, childhood abuse, and other emotional abuse and neglect. Management of hypochondriasis, you allow the patient to talk out their anxieties. You do pharmacological therapy such as fluoxetine 20 mg and psychotherapy such as CBT. Examples of hypochondriasis include 1. Body dysmorphic disorder, 2. Chronic fatigue syndrome. Let's look at them in details. Body dysmorphic disorder. Here there is preoccupation with the belief that some aspect of the physical appearance is markedly abnormal, unattractive, or pathological. The clinical features. There is severe functional impairment, restriction of relationship and employment opportunities, and the patient may seek for unwarranted surgical procedures to make them beautiful or handsome. Treatment. Plastic surgery is usually not indicated. Pharmacotherapy involves giving SSRIs such as fluoxetine 20 mg. If there are delusional features, you give antipsychotics and CBT. Chronic fatigue syndrome. Here there is severe fatigue unrelated to exertion and is triggered by minimal activity and is unrelieved by rest. The etiology is unknown. Management of chronic fatigue syndrome involves keeping a daily record and maintaining minimum tolerable level of activity, CBT, then SSRIs such as paroxetine 20 mg. Now, factitious disorder, also known as Munchausen syndrome. Here, the patient intentionally falsify their symptoms and past history and fabricate symptoms of physical or mental disorder with the main aim of obtaining medical attention and treatment. There are 3 subgroups, mainly wandering when they move from hospital to hospital, non-wandering where they have lived stable lifestyles, and by proxy which is mostly common in health personnel where they say that their children are ill. Management of factitious disorder. You directly challenge the patient. You give them a way out, that's indirect challenge, and systemic change by blacklisting them in Munchausen registers. At this juncture, we come to the end of our lecture. And as usual, our quote is protect your mind, for it is your home. Thank you.